Good evening, Sharon. Can you hear me, Sharon?
Yes, doctor, we can hear you.
Yes. A very good evening to everyone. I think we'll get started in a minute or two. I have to apologize. I got the feeling that this meeting was tomorrow evening on the 20th, but I'm here and we can get started because we have two very eminent speakers with us today. Both of them are oncologists at Holy Spirit Hospital. It's myself and the first speaker today, Dr. Joseph Sequeira. Dr. Joseph did his undergraduate education at St. John's Medical College, and then he went on to do his oncology, MS and oncology training at the Tata Memorial Hospital. He's been in Holy Spirit Hospital for over 25 years. He also works at the Karuna Hospital in Rodrigues and the Cardinal Gracious Hospital at F.I.A.M.C. Joseph has an extensive experience in all types of oncological cancers, but especially in breast cancer. He's at the cutting edge of technology. Joseph is a colleague of mine for the last 2 decades plus at Holy Spirit Hospital. So I'd like Joseph to start the introductory talk. Then we'll go on to Dale, who will give us a little about early diagnosis of breast cancer. And then Joseph will round up with some take-home messages. And then we will go into our question and answer session. So I invite Dr. Joseph Sequeira to please take the presentation forward from here. Joseph, are you on?
Audible? Hello? Hello?
Yes, audible.
Audible? I'm audible, right?
Yes.
Okay. And yeah, can I share my screen?
Yes, doctor.
Okay, full screen. Okay, can you see my screen? My presentation?
Yes, doctor. Yes, we can do.
Okay. Okay. Good evening and greetings from Mumbai, India, my dear friends. Thanks to F.I.A.M.C for organizing such a much needed conference. And I would like to thank Dr. Susan Sauder, Managing Trustee of the F.I.A.M.C, for the beautiful introduction. Breast cancer. Why this topic? So, breast cancer, if you realize, is all around us. Our relatives, friends, everybody has, this breast cancer, such a common disease. So what is breast cancer awareness? Why do we need breast cancer awareness and who needs it? First of all, we know that any cancer is full of myths and misconceptions. We know that early diagnosis improves survival. And most important, if you have awareness of cancer, any unnecessary stress can be avoided of non-cancerous lumps, cysts, etc. in the breast. Who needs to know, who needs to be aware of breast cancer? Both females and also males, because there is 1% of breast cancers which occur in males. Next. So the slide shows us a little anatomy of the breast. As we know, the breast is made up of fat, glands, and connective tissue. It has several lobes, which are divided into lobules, and they end in the milk glands. And from these tiny ducts and many, many tiny glands, they connect together and they end up in the nipple. We know that the breast is a lactiferous gland which produces milk. Now, what is breast cancer? As opposed to a benign, that is a normal lump, what we call fibroid or fibroadenomas. A breast cancer lump is an abnormal, uncontrolled cell growth arising in a breast tissue, which is spreading, wild, and ferocious. It primarily affects women, but about 1% of all cases occur in men. And it is the second leading cause of death in women next to lung cancer in the West. 1 out of 9 women in the US will develop breast cancer in their lifetime. And it was 1 on 20 in 1960. So we have seen such a rapid rise in breast cancer over the past 62 years. Now, in India, cervical cancer was at one time number 1. Now, it is breast cancer in the urban areas, and even in the semi-urban areas, breast cancer is catching up and almost a number 1 among cancers of the females. So a little about what are the types. You need to know that there are breast cancer is not a single entity. It has many entities. So there is something called as a ductal cancer, which is the majority of all cancers, that is, which occurs in the ducts of the breast. Then those that occur in the lobules of the breast are called lobular cancers. And another one which mimics like pus or something like a inflammation or a pus sort of a lesion in the breast is called as an inflammatory breast cancer, and it is the most dangerous of all cancers. In addition, we have ductal carcinoma in situ, invasive lobular, invasive ductal, and a less common Paget's, phylloids. Why I'm telling you all these different cancers? Because they appear differently. We need to do a biopsy to prove which type it is. It's not that one treatment fits all. And so we need to understand that breast cancer is also having many types. So how does breast cancer spread? One, from the breast all around in the breast and the surrounding structures, that is the skin, the muscle behind. It can spread via lymph nodes to the lymph nodes in the armpit, in the neck, behind the sternum. It can also spread via the bloodstream to the liver, the lungs, the bones, and the brain. Now, these are the key statistics of breast cancer to make you aware of the magnitude of the problem. In India, we see about 80,000 new patients every year. In 2021, an estimated 246,660 new cases were diagnosed in the US, with 61,000 non-invasive in situ breast cancer. So it's a huge number. Okay, as we have seen over here. So for women in the US, breast cancer rates are higher than those. So as of 2021, about cases are about 246,660, and the deaths are about 40,500. So 1 in 6 female deaths. There's a lot of difference in the ethnic incidence among Caucasians, Hispanics, Asian, African, and American. The African and Americans have a higher stage and mortality. And as far as the stage at presentation, about 58% present as localized, that is only in the breast without any affected nodes. 32% present with nodes also positive, So that is stage 3. The remaining present as advanced cancers. What are the signs and symptoms? And that is what people, I think, should have a good idea about. And the first and the most important thing is none. And we see a lot of patients who come to us. They have had a sort of a checkup, yearly checkup, screening test, and a part of the checkup, they have had a mammography or a sonomammography, and they found that there's a lump in the breast, which they have, where it's not palpable. And these are fortunately the young patients, and these are patients who present early, and we want such patients. So none signs and symptoms are usually those patients who present to us with early disease. Then they can present as a lump, pain, tenderness, firmness, discharge, bloody discharge, asymmetry, nipple retraction, a lump in the armpit, usually the lymph nodes, or something like they can present as a inflammatory warmth or something like what we think maybe some pus in the breast. Now, these are important. What are the trends that has happened in the last approximately 20, 30 years? We know that the breast is the second leading cause of cancer death in women. Okay. But the death rate from breast cancers have been dropping since 1989. And these decreased death rates are seen among the patients below 50, the younger people who can withstand a very high number of cycles of chemotherapy, etc., etc., etc. So the result of this improved survival or decreased death rate is because of screening and awareness and better treatment. So because the number of patients, they survive of breast cancer, we have a lot of breast cancer survivors. At present, approximately there are about 2.8 to 3 million breast cancer survivors in the United States. So these include women who are treated and those who have also completed their treatment. And the survival rates of breast cancer are dependent at the stage at which they present, and this is a well-known fact. Now coming to treatment, in short, there are 3 main forms of treatment of breast cancer: surgery, chemotherapy, and targeted, which all forms, medical management, chemotherapy, targeted therapy, and radiation. So let's go a little bit into the basics of chemotherapy. So chemotherapy is giving drugs, medications, which can kill cancer cells. They can be given either via the intravenous route, or they can be given orally. They are given usually in cycles, that is, every 3 weekly, every weekly. They are usually given as a combination of 1 or 2 or 3 drugs together. So, and usually about 6 to 12 cycles. So it lasts for several months. How is it given? If it is given before operation, it's called neoadjuvant. If it is given after that, it is called adjuvant. If it is given just as a palliative procedure, it is called palliative. So which drug is best is still unknown, but studies have shown that a combination of these 3 drugs, and that is how we use, and we usually follow the US FDA, US guidelines or the European guidelines in the treatment of the chemotherapy protocols for breast cancer. When is chemo used? In patients who are hormonal receptor negative, they require chemotherapy because there's nothing else. We cannot use anti-estrogen drugs, so we have to give them chemotherapy. So in patients who are hormonal receptor positive, and especially if they're young and before premenopausal, we prefer to give chemotherapy and then add hormonal therapy in addition. If it is given before surgery, I told you it's called neoadjuvant, otherwise it's called adjuvant. So it is important that for a patient to understand why they're getting chemotherapy, which are the drugs that are going to be used, what are the side effects, and all that. And this usually the treating oncologist discusses with the patient before starting the procedure. Hormonal therapy, another form of a medical management. It's also used in addition to some other form of therapy. And it can be used only in those patients in which the tumor is sensitive or has the receptors to hormones. We call it estrogen receptors or progesterone receptors. If they have these receptors, then obviously we can use the hormonal therapies in such patients. Now the problem is in patients whose ovaries are functioning. So in patients whose ovaries are functioning, we giving an anti-hormonal or anti-estrogen therapy may not be of much use. So in such cases, what can be done is we give them something to suppress the ovaries and then give them these drugs. Or in worst scenario, we prefer to even remove the ovaries so that to reduce the estrogen accumulation in the body so that the hormonal therapy works. So in postmenopausal women, we can give all these hormonal therapies. And premenopausal women, we give them by suppressing the ovaries and then we give this hormonal therapy. So can we base our treatment just by knowing that a female is stopped menstruating? No. So sometimes they stop menstruating just with chemotherapy and hormonal therapy may not work. So in some cases, we do try to find out whether they are really postmenopausal, and we could do a few blood tests to see whether their ovaries are functioning and how much of estrogen and progesterone is there in the body. Now, next we go to something called targeted therapy, and I think I thought I'll just say something about it because patients keep asking this question: what is this targeted, doctor? We have heard that there is something which is no side effects and can be this drug, can we take it and all that. So I thought, what is it? And this is called targeted therapy. There is something called as the Herceptin, and these are just like we have hormonal receptors on the cells. We have this HER2 receptors on some of the breast cancer cells. And if a patient has these receptors, they are called HER2 positive tumors. And then we can then give them targeted therapies. So targeted therapies are given usually in addition to chemotherapy. If they are, by and large, targeted therapy by itself is not very effective. We give it with chemotherapy for about 6 cycles, 4 to 6 cycles, and then followed up with only targeted therapy. But by itself, all the studies till today have not found it to be effective. There's one problem about many of these is that it has some effect on the heart, and so we need to be sure that the heart function is normal before we start on this targeted therapy. Another problem is the cost, which is exorbitant. And usually we find that patients who can afford and patients who are covered under insurance are the patients who usually take this targeted therapy. So though it is indicated in a lot of patients, very few can really afford this therapy. Next. So I now and ask Dr. Dale to proceed before I continue with advanced breast cancer.
Joseph, as I understand it, you will be coming on with your presentation again. Presentation. So I now take the opportunity to introduce this young dynamic oncologist, Dr. Dale Rodrigues, who is attached to Holy Family Hospital, and he's also attached to the Hinduja Hospital. He's been with Holy Spirit Hospital Andheri for the last 5 years. Dale is a dynamic and young oncologist who has special interest in breast cancer. He also does a lot of head and neck cancers. He's had a huge stint in oncology, working under the Doyen in oncology, Dr. Sultan Pradhan. I will introduce him again when I sit down. I've been a little busy with work. I've just come in from work. So, Dale, I'm asking you to take it forward from there, and we'll continue the introduction after you've started your presentation, at the end of the presentation. So take it away, Dale, and I hope that this is informative to the audience over here.
Good evening, everyone. Thank you, Dr. Susan. And thank you to F.I.A.M. Center for inviting me to this talk. Am I audible, everyone?
Yes.
Yes.
Okay, can I share my screen?
Yes, doctor.
Okay, can my screen be seen?
Yes, doctor. You'll have to. Yes, doctor.
Yeah, Dale, your screen's on.
All right, okay. Okay. So we'll start off with the breast cancer awareness. So we'll cover the risk factors, prevention strategies, screening of breast cancer, as well as early breast cancer in this talk. So etiology of breast cancer, what are the causative factors, or basically what are the risk factors of breast cancer? So 50% of the patients who we find with breast cancer have actually no risk factor. And we have seen that with increasing age, the chance of developing breast cancer is higher and higher. So as you go in increasing age, the chances of getting breast cancer is higher and higher. So females more than males, as Dr. Joseph Sequeira said, yes, males can have breast cancer, and 1% of population has male breast cancer. So males can get breast cancer too. Family history is a very important factor in breast cancer, where 5 to 10% of the breast cancer patients have a true hereditary predisposition, which in other words means that 85% to 90% of people actually don't have a family history. The risk of developing breast cancer is increased 1.5 to 3-fold if you have a relative, that is mother or sister in the same side of the family, that is blood relative with breast cancer. BRCA1, BRCA2 genes, if someone is positive with BRCA1 and BRCA2, like Angelina Jolie, they have a higher risk of developing breast cancer, about 65 to 85% in their lifetime. Women with a significant family history of breast cancer, that is more than 2 breast cancers in less than 50 years of age, or more than 3 breast cancers at any age, but who test negative for BRCA mutations have approximately a 4-fold increase in breast cancer. BRCA and BRCA1 and BRCA2 are nothing but genes on your chromosomes. On the right side, if you see, BRCA1 is on chromosome 17. Can you see the cursor of mine, the arrow? Chromosome 17, BRCA1, and BRCA2, chromosome 13. The next
Dale is not seen, Dale.
the arrow is not seen, right?
Your cursor is not. Now it's better seen. Yes, now it is.
We'll just go back to the previous slide. So BRCA1, that's the figure on the right side. The chromosome, it's on chromosome 17. BRCA2 is on chromosome 13. The next etiological factor is the most important hormonal factors. So endogenous estrogen in the body, which means that the internal estrogen produced by the ovaries in the female. So whenever there is excess of estrogen throughout the life, we have an increased chance of developing breast cancer. When are those times? When a girl develops early age at menarche, a nulliparous woman, late age at first full-term pregnancy, that is above the age of 30 years. If pregnancy is not attained, she has a higher risk of developing breast cancer. And late age at menopause. These 4 factors have an increased endogenous estrogen levels in the body throughout their life. So they have a higher tendency to develop breast cancer. In postmenopausal, the causes of breast cancers are: one is obesity, and the second is hormone replacement therapy. Both are correlated positively with high plasma estrogen levels and plasma estradiol levels, nothing but estrogen levels in the body. Age-specific incidence of breast cancer increases steeply with age until menopause and then plateaus. A woman with the first full-term pregnancy occurs after the 30 years of age have a 2 to 5-fold increase in breast cancer risk. Breastfeeding is known to be protective against breast cancer, particularly for a longer duration. Normal recommendation for breastfeeding is 6 months exclusive breastfeeding to avoid breast cancers. Lifestyle and dietary factors. So high fatty diets are known to have higher rates of breast cancer than low fat diets. Amount of alcohol consumed in your diet also has increasing incidence associated with breast cancer. Decreased intake of nutrients such as vitamin C, folate, that is nothing but B complex, and beta carotene may enhance the risk related to alcohol consumption. Weight and weight gain appear to play an important but complex role in breast cancer risk, and smoking as another cause of breast cancer. A new thing come up, that is the benign breast diseases. Proliferative diseases with atypical hyperplasia is associated with a greater risk. Atypical hyperplasia is nothing but proliferation or uncontrolled proliferation of cells within the ducts, which cause increase in of cells, ultimately causing breast cancer. Breast density is a new entity come up in the etiology, where we see the mammographic breast density has emerged as an important predictor of breast cancer risk and makes screening detection of cancer more difficult. So if you see in the picture down, I've shown mammographic images of a fatty breast, a fibroglandular breast, a heterogeneously dense breast, and an extremely dense breast. The last image actually obscures mass in the breast, which is missed out on mammography. Women with 75%, more than 75% breast density have a 4.7-fold increase in the odds of breast cancer development compared with those with 10%, more than 10%. Exposure to ionizing radiation at a young age. So these are patients who are survivors of atomic bombs. Those those who have undergone some multiple diagnostic X-ray examinations, and women receiving therapeutic irradiation to the chest. So these therapeutic irradiation are given to patients of lymphoma where they have a tumor in the chest and they've been given radiation to the chest. Ultimately, some scattered radiations cause breast cancer. So what is the prognosis? Prognosis of breast cancer? So prognosis depends on what stage at diagnosis. So we'll deal with the staging in some time, which largely reflects the anatomy extent of the disease and by the underlying biologic subset of the tumor. So biologic subset means what grade of the tumor, how aggressive is the tumor. So that grading system is given on the biopsy. What is a biopsy? We'll talk about it sometime. Defined by the expression or lack of expression of key biomarkers, including ER means estrogen receptor, PR means progesterone receptor, HER2 is nothing but the human epidermal receptor 2. Okay, these are three receptors which in turn tell us about the prognosis, how the prognosis is going to be of the breast cancer. Extent of axillary lymph node involvement. So breast cancer, the lump in the breast spreads to lymph nodes as well as through the bloodstream. So axillary lymph node involvement by a tumor in the breast remains a significant prognostic factor for subsequent metastatic disease and survival. Metastatic disease means spread into the other organs of the body like lung, liver, bone, brain. 35 years and younger patients who have breast cancer have a poorer prognosis due to the high-risk pathological features in this group. High-risk pathological features means the tumor has a higher grade, very aggressive. They are estrogen receptor, progesterone negative, HER2 receptor positive. So when we talk about breast cancer survival rates, we start with stage 0, 1, 2, 3, 4. So stage 0 or stage 1, the survival rate is close to 100%. The 5-year survival rate for women with stage 0 and stage 1 is almost 100%. For stage 2, it's approximately 93%, and stage 3, it's about 72%. But even then, these stage 3 patients can be treated successfully with chemotherapy, surgery, and a combination of all treatment. Whereas stage 4 is metastatic breast cancer, where it is already spread to the other areas of the body. So that the survival drastically drops down from 72% to about 20 to 25%. So the problem comes here, where in India, where 60% of our breast cancers are diagnosed in the advanced stage. We need to change this, hence we have such talks for the public, where we want 60% of breast cancers in India to be diagnosed in the early stage. It is the most common cancer among women worldwide. So what is early breast cancer? So staging, as I told you, staging starts from stage 0, stage 1, 2, 3, and 4. Fourth is the last stage. So if you see the figure on the left, stage 0 means that the tumor has just started within the ducts of the breast, that is within the lining, and has not crossed the lining of the ducts. I have an image on that. We will see that as well in detail. Stage 1 is where the lump is only limited to the breast. Stage 2 is where the lump now has grown in size and has spread to the lymph nodes in the underarm or the armpit. Stage 3 is where it has crossed beyond now the surgical margins, has spread into the underarm, that is the armpit, and also spread into the nodes of the chest, inside the rib cage, or it has spread above the collarbone, above the clavicle. And stage 4 is spread to the other organs, that is the brain, lungs, liver, bones, supraclavicular area. So early breast cancer is stage 0, 1, and 2. Stage 0, 1, 2 is early breast cancer, and this is why we need to educate people, because stage 0, 1, 2, the survival rates are very high. So chances of living longer is much much higher if you are diagnosed in the stage 0, 1, 2, that is early breast cancer. So it's defined as a tumor which is up to 5 centimeters and there is no nodes in the underarm, that is N0, or up to 3 nodes involved in the underarm. And locally advanced or stage 3 is where the tumors of any size, it can be range from 4, 5, 6, 7, 8, 9 centimeters and multiple nodes in the underarms. And stage 4 is where it is spread to the other organs. So again, this image, stage 0, survival rate close to 100%, stage 1, again close to 100%, stage 2, about 93%. Stage 3 onwards, the survival rate drops down 72% and stage 4, 22%. So early breast cancer, what is it? I've told you up to 5 centimeters and no nodes involved. Stage 0 is limited to the ducts that we call as ductal carcinoma. Stage 1 is a lump in the breast. Stage 2 is a lump in the breast with nodes in the axilla. So I think Dr. Joseph Sequeira already covered the symptoms. I'll just one slide on the signs and symptoms of early breast cancer. So a lump or something as a hard feeling in the breast or a hard rock-like feeling in the breast is something not to be ignored. As small as possible, report it to the doctor. A pulled in nipple, that is, if the nipple has recently got pulled inside, inwards, retracted towards the chest wall, this is not a good sign. So please report this. It could be something which is an underlying, is a tip of the iceberg, we would say, that there is a lump inside and it's pulling the nipple inwards, or a dimpling of the skin, that is the lump pulling the skin towards one side or towards inwards, towards the chest wall. These are early signs of breast cancer. A dripping nipple, that is blood stain discharge from the nipple, is also an early sign. Whereas the last two, that is the skin changes and redness or rash over the breast, is an advanced sign. So the early signs and symptoms, again to revise, is a lump in breast, pulled in nipple, a dimpling or puckering of the skin, a dripping nipple, that is blood stain discharge from the nipple. So what are the tests that we do in early breast cancer? A triple assessment that we call. So triple assessment is nothing but a clinical examination by an oncosurgeon, which is the most important thing. That is seeing where the lump is. Is there any nodes in the underarm, in the armpit? The second thing is imaging. Imaging is nothing but an X-ray of the breast, known as mammography. It may not be combined with a sonography. That's a sonomammography of the breast. The third is an F.I.A.M.C or fine needle aspiration cytology, or a true cut biopsy. So what are these things you will see? So true cut biopsy is nothing but a small piece of tissue. A biopsy is nothing but a small piece of tissue which is removed from the lump which is in the breast. Everyone sees the lump in the breast, and this is the needle going through the skin of the breast. So this is done under local anesthesia, where we numb the skin out here and the needle is put into the lump and a small piece of tissue is removed from this lump and it is seen under the microscope. This confirms the diagnosis of breast cancer. And the site of where the needle goes in is very small puncture, that is about 3 to 4 millimeters, and almost never painful. So these are the needles that we use. This is an automatic gun. This is a manual gun where we use for true cut biopsy. So there are some times where we do a biopsy, but it's not possible to get a diagnosis. So these are the indications where we do an open biopsy, that is, take a small incision and take out whatever is actually seen on the mammography or whatever is doubtful. So those are the indications where it is very small, where there's just micro calcification sometimes seen, or there's diagnosis of an atypical ductal hyperplasia, diagnosis of pleomorphic lobular carcinoma in situ, or a lack of concordance between imaging findings and histologic diagnosis. That means they are not matching. Means we are seeing something else on mammography which is indicative of a cancer, and the biopsy comes as negative, means not a cancer. So in such situations, we can't tell the patient, please go home. We need to tell the patient, okay, we need to do something further, and that is an open biopsy. Radial scar or complex sclerosing lesions, these are seen on mammography, and papillary lesions. Papillary lesions are very tiny lesions which are difficult to biopsy. Hence, surgical biopsy needs to be done. So this is what I was talking about as stage 0. It's known as ductal carcinoma in situ. What does it mean? It means, so what is Dr. Joseph Sequeira already mentioned what is cancer. That is nothing but an uncontrolled proliferation of cells. Proliferation means increasing number of cells, normal cells increasing in their numbers. So proliferation of malignant appearing mammary ductal cells without evidence of invasion. So everyone can see the cursor again. So number 1 is the normal lining of the ducts of the breast. Second is hyperplasia, where the cells have increased in number, but they are again normal looking. So that is called as hyperplasia. And the third one is atypical ductal hyperplasia, where the cells have increased in number, but there are few cells which are also different in size, shape, and characteristics, the yellow cells. So that is atypical ductal hyperplasia, where we need to do an open surgical biopsy in such cases. And the fourth, if you see, is number of yellow cells have increased in size. So this is a proliferation of malignant appearing cells. That is, the cells are not normal. The purple cells are normal cells and the yellow cells are abnormal cells. So these look like cancer but have not invaded the purple lining, that is the basement membrane. So it is not invaded. And the fifth one is ductal carcinoma with microinvasion. There are few cells going beyond the basement membrane, that is microinvasion. And the frankly invasive ductal carcinoma that we call as a frank breast cancer is these cells have crossed the basement membrane, and that's when they spread into the lymphatic system of the lymph nodes and then travel to lymph nodes of the underarm. So ductal carcinoma in situ is number 4 figure, is stage 0, where very prognosis. If you're diagnosed in this stage of breast cancer, you can almost say that survival is 100%. Management of this ductal carcinoma in situ is just local excision, that is removing that area which is seen on the mammography, and consideration of giving some radiation treatment after that. Sometimes if the area is very large, then if you think of a complete breast removal followed by endocrine therapy, that is tablets, hormonal therapy. Treatment of the axilla, in short, the ductal carcinoma in situ, as I told you, doesn't spread to the lymph nodes. So it need not be, the lymph nodes of the axilla need not be checked if only a wide lumpectomy is being done, that is only if the lump is being removed. But if an option of removing the complete breast is being given to the patient, then something known as a sentinel node biopsy can be done during the same procedure. So we'll go to early breast cancer management. That was, we finished with stage 0. Now we'll see what we do in stage 1 and stage 2. So treatment options in a capsule. So what are the entire range of treatments that we have? What are the entire range of armor that we have against breast cancer is, first is surgery, second is radiation, third is hormonal therapy, fourth is chemotherapy, targeted therapy. Now all these, when I say 1, 2, 3, 4, doesn't mean that they go in that order. It can be anything first and anything last. So sometimes we give chemotherapy first before radiation. As Dr. Joseph said, it's called as neoadjuvant chemotherapy, followed by surgery, and followed by some other treatments beyond that. So everything will depend on what type of breast cancer is got on the biopsy results, which I told you as whether it's an invasive ductal carcinoma with the receptor status, that is estrogen receptor, progesterone receptor, and the HER2 receptor. So surgery, radiation, hormonal therapy, that is estrogen blockers, and chemotherapy, and the targeted therapy. Targeted therapy, as Dr. Joseph said, is known as the HER2 receptor blocker. That is trastuzumab. That is the one which is tried and tested for maybe about 5 to 10 years now. And the second newer one that has come out is pertuzumab, which is a newer variant, but very, very costly. So what are the options for a breast cancer treatment in the early stages? So there are two options in breast cancer in the early stages. One is breast conserving surgery, where we remove only the lump. Only the lump is removed and the lymph nodes in the underarm to check whether it has spread. So this is called the breast conservation surgery, where the breast is preserved and a cosmetically appearing breast should be aimed at. The second surgery that we do is a mastectomy, that is a modified radical mastectomy, which is nothing but the complete removal of the breast. So the second image is showing that where elliptical incision is taken along the breast and the entire breast is removed below the skin and the skin flaps are closed over it. And the cut that you get is a fairly decent cut, where just a linear line along the chest wall. Along with the complete breast removal, now recently we have started doing reconstructions at the immediate setting, that is a complete breast removal with a complete breast reconstruction. So we have good plastic surgeons nowadays who are doing it for us, and outcomes are very good. So who decides whether we need to do a breast conserving surgery or a modified radical mastectomy? Must remember that survival rates are same in both options. That is whether you do a breast conserving surgery or you do a radical mastectomy. But it depends on the tumor location and the mammography findings. So in all, actually breast conserving surgery, the expense turns out a little more than a radical mastectomy. Why? Because as I told you before, breast conserving surgery has to be combined with radiation. So it becomes compulsory. Breast conservation surgery always has to be combined with radiation to complete the entire treatment. So in that situation, many patients opt for MRM, that is complete removal of the breast, just to avoid radiation. But again, we tell them that your final histopathology report, again we need to decide if it comes really bad, that your final report, the final histopathology report is very bad. That means there is multiple lymph node spread, the tumor is very aggressive, the spread to the lymphatic channels. Then we need to decide again whether we need to give you radiation or not. So just one small slide on the reconstruction after radical mastectomies. So advances in plastic surgical techniques have made immediate reconstruction an option for most of the patients who undergo mastectomy. This is being routinely done at all hospitals, where we do a mastectomy and the plastic surgeon comes in then to reconstruct the breast. So there are different types of reconstructions which can be done. So in the center, if you see the images, so for the first one is a simple implant, what we call as silicone implants. It's the age-old ones which were being done before, and tissue expanders were used. And the latissimus dorsi flap. Latissimus dorsi flap is a flap which is taken from the back muscles and replaced in front to recreate the breast. And the 2-3 new flaps which have recently come is the transverse rectus abdominis muscle flap, or the tram flap that we say, and the deep inferior epigastric perforator flap. Abroad in the US, this deep inferior epigastric perforator flap has become the gold standard. It means they do this flap all the time, unless there is some contraindication. So deep inferior epigastric perforator flap is nothing but the fat of the abdomen has transferred from the abdomen, the lower abdomen, to the breast. So patients actually are happy because they get a reconstructed breast along with a flat tummy. The last one is the superior gluteal artery perforator flap. So prevention of breast cancer, what can we do to avoid being prone to breast cancer? So we divided into modifiable and non-modifiable risk factors. There's some things which we cannot correct in our life. That is the personal history of breast cancer, gender, the family history of breast cancer. So these 5 things cannot be corrected. They're non-modifiable. But what we can do in our life, modifiable risk factors. These are the things which we need to do in our life. So don't smoke. Limit the alcohol. I would say rather just stop alcohol if you can. Control the weight. So what is the ideal weight for a woman or rather any person is your height in centimeters minus 100. So if my height is 5'6", so I'm 165 centimeters. Am I audible?
Yes, yes, doctor.
So control the weight. So ideal weight, easy to calculate formula is your height in centimeters minus 100. So my height is 5.6, that comes to 165 centimeters. If you minus 100 from 165, my ideal weight should be 65. So try to get your weight approximately around that amount to have a good control on your weight. Limit dose and duration of hormonal therapy. So try to avoid any hormonal therapy given. Be physically active, do a regular 30 minutes exercise every day. More fruits and vegetables in diet. As I told you before, breastfeeding is protective. Any mother should be advised for lactating her, for breastfeeding her child for at least exclusively 6 months. So screening. What is screening? Screening is nothing but the X-ray of the breast, that is the mammography, as I told you before, where screening means someone who does not have any symptoms and is going for a routine test and gets a mammography done as a routine every year. So who should get it done? So the screening strategies according to the American guidelines. So there are many guidelines which we follow, actually American, European, French guidelines, Indian guidelines, but overall we follow US and the Indian guidelines. So these are the US guidelines where they say you should start after the age of 40 years, start getting mammographies done every year. Whereas if you see the Indian guidelines, 50, mammography. So screening helps in detection of lesions, that is detecting early breast cancers. So this is something new which I found on the net, so I put it on the slides. So this last gray area, that is we want tomosynthesis, 3D mammography. This is something which has come up new, and this is something which we have at Holy Spirit Hospital. It's a very proud thing to have for us oncologists, that we have a 3D mammography machine in Holy Spirit Hospital. This and all the guidelines, almost all the guidelines, it tells us that it improves the cancer detection. It reduces the recall rates, improvement in detection rates. And so 3D mammography is nothing but something like a CT scan of the breast. And it is easily done. It's just almost the same as mammography. So the take-home message for this talk would be breast self-examination, how to do it. So breast self-examination, how to perform a proper breast self-examination is 3 ways. One is to stand in front of the mirror while bathing, and while lying down. 3 methods of doing it. So in front of the mirror, stand with your arms by your side, over your head, over your hip, and slightly bend forward. So 4 positions that you need to see yourself in front of the mirror. Again, by your side, over your head, on your hip, and slightly bend forward. The first time you do this examination, study, feel, and look. Examine regularly. Look for any changes. Changes what? What changes? Like size of the breast. Compare both the sides of the breast. Nipple inversion, any nipple discharge, pulling of the nipple to one side, any skin changes over the breast, dimpling, any discharge from the nipple, or any bulge over the breast. Don't take these things lightly. You should report it if at all you are seeing such changes in the breast. The second way is while lying down. Lying down, because the breast becomes more flatter and it is easier to palpate. So place a pillow under your shoulder. This will raise that part of the chest wall so that the breast can be properly. Your hand behind the head and check the entire breast with the opposite hand. Finger pads. Now, finger pad word is very important. Why? Because we do not need to feel between fingers, not between fingers, but with the flat of the hand or the finger pads. That's when you will feel a proper lump. Check the underarm or the armpit. Check for nipple discharge and check the opposite side. So the pattern of which you check should be also systematic. Otherwise, you will miss out an area in the breast. That is a swirl pattern or straight up down or a compass into out. You can choose any method to do. Important thing is to measure all the quadrants of the breast, that is right, left, inner, outer, upper, lower, and the center. And the third way of doing it, easy way, is while in the shower, preferably with soapy hands, that is apply soap on the hands and feel the breast. This will help to feel even the smallest of smallest lump in the shower, because it is more comfortable as well in the shower and you can examine both breast underarms easily. Again, in the same pattern, swirl pattern, straight up, down, and or into, out, or out in. So these are the positions that you need to sing. Hands by the side, hands overhead, hands on the hip. Check for nipple discharge. Feel with the flat of the hand, that is the finger pads, and while lying down with the opposite side hand, same side hand behind the head. So that was all about early breast cancers. A few slides on the ethical issues that we have in breast cancer. So ethical issues would be that very important to educate these patients who develop breast cancer. What is the cancer? What is the prognosis? How is the survival going to be? How she's going to face the community if she has a complete breast removal. So these all education to the patient and as well the relative. And informed consent. Discussion of all the relevant medical issues so that she understands the ramifications of diagnosis, treatment, risk, and benefits of undergoing or refusing treatment, and enables a patient to make a reasoned, autonomous decision, which means that we need to explain to them that her breast is going to be partly removed or completely removed. If what is going to happen, this early breast cancer will transform into an advanced breast cancer and it will spread to the other organs. Her survival rate will drop down. These are things we need to discuss with them, and she needs to take an autonomous decision. So sufficient time must be allowed for development of this understanding. So often in our OPDs, time is a very important factor where we tend to miss out. Of course, we don't do it on purpose, but we tend to give maximum amount of time as much as we can to a patient who deserves the time. So apprehensive patients tend to be selective in hearing of explanations. So when they are scared, they will not hear some things what you say. To hear what they are afraid to hear, what they want to hear, and what they are prepared to hear. So we have to give them sufficient time to develop this understanding of breast cancer. and it comes as a shock to them, where we need to explain, give them time, give them a comfortable seating in a calm environment. And then we need to discuss the funding for their healthcare and their limitations, whatever they have, they need to discuss with us. So next thing that we need to do is respecting the patient's right to privacy. We can't openly tell anyone about this breast cancer to any other family member if she doesn't wish to tell. Permission to access such information if we need to do a medical intervention and research. In situations like familial breast cancer, where the patient has a strong family history of breast cancer, which I told you is more than 2 relatives less than 50 years of age, or more than 3 relatives having breast cancer less than at any age, it is recommended that we as oncologists need to encourage such patients to disclose these information to their relatives who are going to be at danger. So usually we don't have this problem, and every patient who develops breast cancer doesn't want their family member to develop breast cancer. And we usually don't face this problem that they don't want to disclose. So all of them want to help their relatives. Ethical responsibility towards the oncologist. So towards me as an oncologist, performing medical practices based on the latest developments in the field of medicine is the first and most important step in providing moral medical service. So I need to be up to date with everything. A tumor board meeting. What is a tumor board meeting? So tumor board meeting is nothing but a consensus, that is a meeting between the chemotherapy doctor, a surgeon, an oncosurgeon, and a radiation oncologist for cases which are a little unusual, or the presentation is not sound, or sometimes treatment is not straightforward in oncology. So which gives combined decisions from all the consultants to develop a sound treatment decision for that patient. Respecting patients' religious, cultural values, treating them respectfully, politely with compassion and fairness, avoiding various types of racial, religious, cultural, and sexual discrimination. So there are patients who say that we don't want surgery on a Tuesday, Mangalwar hai, Shaniwar hai. So we have to respect their wishes and move things up and down for them. Breaking the news of cancer. Breaking the bad news, including the diagnosis of breast cancer, recurrence, or metastasis, is morally recommended. Delivering such news should be step by step in a private and calm environment, and during a meeting session in which the physician has enough time to communicate with the patient and family. Breaking the news of cancer is a hard way. We usually make them sit down comfortably and explain to them that treatment is going to be needed, but you will be fine and your survival will be very good if it's early breast cancer. At the same time, if it's advanced breast cancer, that is stage 4, patients whose diseases are in an irreversible status and death is imminent, you advise the family of care. All medical intervention should be performed in order to reduce the patient's suffering, enhancing their comfort, and responding to their mental, spiritual, and emotional needs. Medically futile treatments could be foregone, that is withheld or withdrawn after informing the patients or surrogates. That is, sometimes patients come breathing difficulty. So we should try to avoid putting them onto a ventilator, because we know that things are not going to come out very well even if we put on the ventilator. Mainly because of the scope of respecting the patient's decision is limited to those medically approved or accepted beneficial choices. Foregoing, withholding, or withdrawing life-sustaining treatments like a ventilator should be decided by consultation with clinical ethics committee, and also after obtaining an informed consent from the patient or their family members. So thank you for your kind attention. I'll go back to Dr. Joseph Sequeira, who will continue with advanced breast cancer. So remember, best protection is the early detection of breast cancer. Thank you.
Thank you so much, Dale, for this wonderful presentation. It's been very comprehensive, very simply explained, extremely well put. And I also have to inform the audience, you're not just only interested in head and neck surgery, but you also have a fellowship from the prestigious Memorial Sloan Kettering in New York for head and neck cancers, and cancer base skull surgery from an Italian university. So Dale, way to go. Wonderfully explained. I have a few questions up for you, but I think we'll allow Joseph to come in at this time because he has a few points to clear up regarding advanced cancers, and then we'll open it up for the chat. Over to you, Joseph, if you're around.
Yeah, I'm around.
Yes.
I'm still around.
Yeah.
Okay. Can you? So can you hear me?
Yes, we can, Joseph.
Yeah, okay, good. So now proceeding to advanced breast cancer, which is stage 3A, B, C, which has already been explained by Dr. Dale, so I won't go further into that. It is breast cancer which is spread to lymph nodes around. And stage 4, which is breast cancer which is spread to other organs. Yes. Previous. Next. Okay. So now, stage 4 cancers are cancers which have spread beyond the breast to other parts of the body, like bones, lungs, liver, brain. And now we know one thing. Most of these cases are not totally curable. We can control them. In some cases, the tumors do disappear with various forms of therapy, but at some point of time, they reappear. And that is the question, and it throws multiple medical, ethical, legal, and various questions. How do we treat them? So obviously, we have to go systematically in such cases. We have to see the pockets of these patients, how much they can afford, and then we usually proceed with their treatment. We have to choose something which is less costly, something which is less, has less side effects, and something which is more safe. So how do we start? Okay, so what are the treatments which we have? As we know, for stage 4, we have hormone. Surgery is at the back. We have to treat the whole body. The whole body has cancer. So we treat something with therapies which can reach all over the body. So obviously, medical treatment forms the mainstay in such stage 4 disease. So we have hormone treatment, chemotherapy, targeted therapy, and a combination of all these. Surgery or radiation is sometimes used, when we may be wanting to remove a fungating tumor for the patient's well-being, or radiation is sometimes used for pain control, or a localized tumor which we feel that it can be controlled with radiation. Now we know that with all these treatment, we can possibly shrink tumors and allow the patients to live a better quality of life. So how do we always try to choose something which is safer, less side effects, and then we try to go for in the opposite direction, then something with more side effects. So we choose. So if we know that hormonal treatment is one of the treatments which has the least side effects, and so we try something like that. So patients who are postmenopausal, you before, we would prefer to start with hormonal treatment or anti-estrogen therapy. And those which are hormone receptor negative, then we have a problem. And therefore, we are forced to use chemotherapy in those patients. In those patients which have targeted positive, we can add those targeted therapies if they can afford. And I'm very, very clearly stating if they can afford, because we know that these tumors are not totally curable. So patients who really can afford, we can give them some more years of life, or we do advise even costlier therapies. Now, when do we stop? And that is the legal, ethical, and medical ethic. When do we stop? We stop either when the tumor stops responding to whatever therapies we are trying, or when the patient cannot afford. In India, that's the most common, or when the side effects are too much and then they cannot tolerate the therapy. So they cannot tolerate the therapy, or they can tolerate, and the tumors don't respond. And then the last thing is when they run out of funds. Next. So local or regional therapies, I've told you, radiation is sometimes used just as a palliative setting for pain control, fungating tumors, stopping bleeding, or whatever in such cases. Surgery is sometimes used just for, as a fungating, if you can remove a tumor just so that the patient has a better quality of life. For bone meds, there are a variety of palliative drugs available, like zoledronic acid, pamidronic acid, vitamin D. And then after that, at least they get some amount of control from bone pains, which are really very, very difficult to treat. So, hormone treatment. Now, if they progress on hormone treatment, what we do, fortunately, now we have a wide array of hormonal drugs. So we change, we mix, we match, we jump. We start with tamoxifen, aromatase inhibitors like letrozole, anastrozole. Then we go into other drugs, and then we use everolimus. So we keep on mixing and matching, and we see the response. And if they respond, well, it could continue as long as they think. If they progress on chemotherapy, again, many drugs available. So we mix and match till there are no side effects, and we see a good response. And same thing with HER2 drugs. We again mix and match. We start with Herceptin. We progress to pertuzumab, and then we go to Cadsil. So these are the three, but expensive. So very rarely we can really go to the end in HER2 drugs. Now, a little more on breast cancer. What is going on in breast cancer? First, about the causes. Now, there are many studies which are going on what are the real causes, because there was a paper in New England Journal of Medicine about a few years back, and they said that the major cause of cancer when they went into etiology is, I think it was around 35%. They called it bad luck, means we don't know the causes. So there is something that we really don't know, and research is going on what are the causes. So there are genetic studies which are going on. People are looking at environmental issues. And now there is a study which is going on where they're studying the sisters of patients with breast cancer. And this is a study. They have enrolled about 50,000 women, and they are studying them for 10 years to see, they're looking at everything, their lifestyle and all that, genes, lifestyle, environmental factors. And an offshoot of this sister study is the two-sister study, which is looking at the early onset of breast cancer in such patients. Now, is there any drug that can be used to reduce breast cancer? And I think that everybody will be asking for that. You have two breasts, you are worried that you might develop breast cancer. Is there a drug? So there were drugs. And I remember in the 1995, when we were doing a study at Tata on a drug called proloxifene. And there was a drug called raloxifene, which also had just completed phase 3 studies. Proloxifene, when I was doing it, was a phase 3 study for breast cancer. Now, all these drugs, that is raloxifene, proloxifene, and there was another drug called idoxifene, they were found to be not superior to tamoxifen. And so, though the research was conducted, they never came into the market. Now, one of these drugs called raloxifene was found to help in preventing osteoporosis. So it started being used in US to prevent osteoporosis. And an offshoot of this was that they also found that taking it may reduce the risk of breast cancer. So it was a drug given for osteoporosis with added advantage that it might reduce breast cancer. So that is raloxifene. The other drugs which were used is ferrintide, that is a drug related to vitamin A, and dietary supplements, and hydroxytyrosol. These are all the drugs, olive oil components which are used, which are still in the experimental stage. Now there are ductal carcinoma in situ. We know it is an early thing. There are studies on how to detect it early and how to treat it aggressively or non-aggressively. Then there's a new, we do use in some cases called circulating tumor cells, CTCs. It's a blood sample you take and find out whether you have metastatic cells in the body. That is a sure shot. Then you know that you have metastasis. And molecular based imaging are the newer imaging tests which are used. So other things are in surgery. You can have oncoplasty, where you can match the opposite breast by reduction, mammoplasty, and all that. So those are other things. Then drugs that target HER2, I've already told you all the drugs available. Then hormonal therapies, drugs which improve our palbociclib and everolimus. They help to improve the effect of hormonal therapies. There are PARP inhibitors and angiogenesis drugs like bevacizumab. There are many drugs which are still they are being used, but not as a consensus. Thank you. So the meeting is now open for any questions or whatever.
Joseph, I've got a couple of questions lined up over here.
Yeah.
So I'm going to begin by asking you, there's somebody who's asked, have you seen breast cancer occur in pregnancy or in women who are lactating? And what would be the prognosis for such women?
I think we both saw one long back, and see, breast cancer during pregnancy, I've seen many in Tata, and even in Holy Spirit, I think we have seen a couple of them. You and me have seen that thing. What is the prognosis? Yeah, that's a big, no, the prognosis is one issue and the treatment is a big issue. How do we treat such a patient? We have a patient who's got a child. We have to then plan what is the treatment. So, one problem about the prognosis is that that the treatment options are limited itself. So that is what, if it's an early pregnancy, then, there's a big problem, ethical issues of abortion and all that, and late pregnancies, then yes, we have better prognosis, because then we can allow the patient to deliver, we can do a cesarean, deliver early and start the treatment early. Now, treatment in pregnancy, we know that the chemotherapy, if it has to be given, is a problem. either first trimester, second trimester, third trimester, it's different. So that's a problem. But the basic issue is, can we remove the tumor is the issue. And I think if something can be done to remove the tumor, the primary we are talking, but the breast, at least then the prognosis is better. But by and large, pregnancy tumors, breast cancers during pregnancy have a little worse prognosis than normal. And I don't know whether it is because of the related surge of progesterone by the estrogen progesterone mismatches, or whether it is because of we are not able to probably treat on them.
There is another very similar question which I'll put to Dale. Is it possible for a woman to have a pregnancy after she has been treated for breast cancer?
Yes, it is quite possible to have pregnancy after treatment with breast cancer. But we usually advise to abstain from getting pregnant at least 2 years, 3 years after the whole treatment is over, that is chemotherapy and radiation, and letting a normal cycle start. So yes, it is possible to get pregnant even after.
One question regarding age of breast cancer. There's somebody who's asked, it's known that younger and younger women today are being affected with breast cancer. What is the reported age, the youngest age of a woman who's been reported with breast cancer?
The youngest that I have seen is 28 years, but I think Dr. Joseph will have a even bigger span of patients to say that he has seen younger. But 28 is the age that I have seen.
22, no, 20, yeah, around 20 to 23. There are two in sarcomas, malignant sarcomas, and invasive breast cancer. So invasive breast cancer is around 23 is what 20 to 23 is what I saw. But sarcomas are much younger, so we have seen around 18, 20 years.
One question regarding self-breast examination, which I'll put to Dale because he talked about screening. What is the sensitivity of this self-breast examination? When does a woman do it during her menstrual cycle? Who would like to take the question? Is it Dale or is it Joseph?
So during the menses, obviously the woman would have little heavier breasts, so we wouldn't advise them to do a self-breast examination during the period of menses, at least during that period, and at least after about 1 week after that. But maybe somewhere mid period time, and that would be a correct time to do a breast self-examination by layman public. But for
sensitivity of picking up breast pathology or neoplasms by a self-breast examination, is there any sensitivity that you could put figures? How sensitive is it?
I wouldn't know the sensitivity percentage, but it is lesser.
Okay. See, this is what we have done in Tata. This was a study which we did. So there was something called as breast self-examination. But in India, I think that is a little bit of a problem among the little lower class or a little uneducated people. So this, the Mitra is the one who initiated the study in India, and we called it breast examination by a trained healthcare worker. So self-examination in India is a little tricky thing. So the pickup rate is not maybe good in some patients, may not be good in the other patients. And more important than that, it depends upon how big your breasts are and how dense your breasts are. And what is acceptable, and we have done a study in that, I was part of that, so is breast examination by a healthcare worker. And that the uptake up, this is much better.
Okay. Just an add-on to this, Bayer, one of the big multinational companies, have taught women who have a problem with their eyesight, who are mostly blind, to increase the chances of picking it up in a breast examination. They seem to have better tactile senses.
Tactile.
Yes, and they seem to say that the breast examination done by these visually challenged women have a better sensitivity than other people. But there's nothing proven scientifically, but this is what this multinational company is doing. A quick question about the radiation dose in mammography, and does the 3D tomosynthesis have less radiation than the regular analog mammography?
Mammography is the X-ray dose is hardly 0.1 rad, so it's lesser than a normal chest X-ray. It's a very low radiation dose that goes for mammography.
And when does a woman start doing her mammographies? Another question. And how often?
So as I said, in the American guidelines, it is 40 years you start every year. But in Indian case scenario, 45, 50 years also, one can start screening for breast cancer.
Low risk.
Joseph, I would have to ask you this question. How many women come with advanced disease with fungating tumors from the breast? And why is it that women wait till this long?
We do see, I think, if you talk Holy Spirit, if you talk then towards rural areas, Vasai, Virar, or this thing, the numbers are different. So in Holy Spirit, I would find lesser number, maybe about 10%, 5 to 10%, not more than that, with fungating tumors. But in rural areas, much more. It's about almost 20, 25, 30%. Why they come with this? I think most often is they are shy to reveal that there's a problem in their breast. It is something which they don't like to tell others. And another thing is sometimes the fungating occurs, suddenly. But there's a lump in the breast that is something which they feel, it's something normal. It's something normal. They are not aware, and that's what awareness is all about. They're not aware that there's something wrong with the breast. So there's a lump and they ignore it, and then one day it suddenly fungates. So a fungating is a sudden occurrence actually of a lump, long standing.
Dale, a question for you. Many women have fear about the body image following mastectomy. Some women equate the mastectomy as severe as even calling it like a death. They kind of equate a mastectomy to that much of trauma as a death. How would you counsel a woman or counsel women as to overcome this fear? Because most women shy away from the doctor because of the fear of a mastectomy. How does one counsel the public as regards this?
So this is a very common thing. What happens in the OPD scenario where the patient, we tell them that you need to have a complete breast removal and they're suddenly taken aback. It's a normal scenario which happens. So what we tell them is that, see, it is required to save your life. That's the most important thing. The second thing is cosmesis. And then we tell them that there are options for cosmetic replacement, that is reconstruction of the breast. If at all she is too worried about facing the public after the surgery, the immediate reconstructions can be planned with a plastic surgeon. We do it quite routinely for breast cancer. But normally what happens is they accept it ultimately. It takes some time for them to accept, and they do accept it. And then we tell them that you can use an external prosthesis to cover up the defect that is seen externally. And that is pretty, it's quite okay for them. Most of them apply to that as an external prosthesis.
There's one question which asks, why is mammography not used as often as in the West as a screening technique for breast cancer?
Mammography per se is being routinely advised by all doctors to be done for women above the age of 40, 45 years. But the number of people doing routine screening tests are very less in India. So
What would you have to explain to a patient
breast cancer
if
awareness.
they're doing mammography rather than having, pick up advanced disease? Because mammography would pick up the disease in its microscopic stage rather than go in for, even when it's a palpable lump, it's already a clinical disease, which is probably stage 2 and beyond.
Yes, exactly. So the reason why we do mammography is to pick up some things which are before the development of cancer. That is something known as microcalcifications or a ductal carcinoma in situ, where it is still, the survival is very high. There's almost 100%. So mammography helps in that way. And by educating people by such talks, they tend to go out and get mammographies done.
I think one thing you must understand, that mammography, why is mammography more in the US, is because mammography is part of your insurance coverage, and to cover that, they want you to undergo a mammography. It is done either by the companies. In India, insurance is not, or is not such, it's widespread. And that is the problem. If something was part of your insurance and something which is done by your company, which is paid for by company, then universal, I think it would have been more, it would have been done more often. So we are comparing apples and oranges, and I don't think this, until the health infrastructure in India improves, nothing will improve. You can't tell a person, yes, go and do, but they have to pay for it. So why spend? So it is that problem. And abroad also, people are getting it covered. That's it.
I wouldn't agree with that justification, because if we can spend for other things in life,
I know. Yeah, but
for health and preventive health. I
yes,
think
but
in time saves 9. There's a question for you, Joseph. Does breast implants, silicone breast implants, cause cancer?
Breast implants causing cancer? No. But there is a study which, the breast implants have burst and all that, and they have caused complications. But breast implants causing cancer, I think a very small, there's one study which is showing about, something that, but I don't think it ever came into one study which said, yes, long-standing. And it was one brand. And I think that then finally that implant was recalled. That's all. I don't think overall breast cancer implants, and we used to use it frequently in Tata at one time before all LDs and all.
Dale, there's a question which asks, is it necessary for a woman who has breast cancer to have her uterus and ovaries removed?
Not necessarily. Unless the tumor is strongly estrogen receptor positive, then only there's some studies which say we can do a bilateral salpingo-oophorectomy, which will cut down the total estrogen levels. But it's not done routinely. We do it for certain cases who are young patients, high risk diseases where there are a high chance of relapse. There we will do a bilateral oophorectomy for them. Only estrogen positive, ERPR positive tumors. Younger ladies. But
I covered that in my talk.
Joseph covered that. Yes.
I covered that.
That has come in over here as
Okay,
regards.
so it's very clear. Premenopausal women with ERPR positive tumors. Premenopausal ERPR positive tumors. We need to get, and suppose you want to give them hormonal treatment. Now you give them hormonal treatment, but the ovaries are producing a lot of estrogens. So obviously your hormonal treatment will not work. What do? We have to suppress that. Either you can give them LHRH, that's an injection which suppresses the ovaries, medical oophorectomy, or a cheaper form is remove both the ovaries. Now your second part is removing the uterus. Now tamoxifen, if you see, does cause proliferation of the endometrium, and we have seen endometrial thickness increasing, and there is a 2% chance of endometrial cancer in patients taking tamoxifen. So in those patients, when the endometrial thickness is increasing and if they have bleeding or something, sometimes as a prophylactic, we do remove the uterus. That's the thing. But and sometimes if the endometrial thickness is above 7, about 6 or 7, then do a endometrial curettage, find out whether it is CA and then go according. So in those two cases is where uterus and ovaries are definitely have to be removed. Very simple.
There's a roundup question for you, Dale. It's about chemotherapy. Does a woman always lose her hair when she takes chemotherapy? And how many cycles of chemotherapy are usually recommended?
It's the most common asked question when we say chemotherapy is required. Unfortunately, we are not able to counter the side effect of hair fall in chemotherapy. Every other side effect like vomiting, weakness, everything can be countered with medicines, but hair fall is something which we are not able to counter. So what we do is the recent thing that I try to do with patients is I tell them, you can take out the hair at the start of chemotherapy and make a wig out of it and use the same hair as your own hair as a wig. And the duration of chemotherapy, I think Dr. Joseph will have an idea of how long and regimens of chemotherapy. There are different regimens of chemotherapy under US guidelines, European guidelines, and NCCN guidelines. So he will have a better idea.
Okay, so chemotherapy, very, very simple. Now, basically, chemotherapy is either you use if you want to use chemotherapy with targeted or chemotherapy by itself. Chemotherapy by itself is usually 6 cycles at intervals of 3 weeks. That's simple, 6 cycles of chemotherapy. Okay, now when you use targeted therapy and chemotherapy, then the problem is since targeted therapy cannot be used with a drug called epirubicin or doxorubicin because it is cardiotoxic. So what we do is we divide it into 4 plus 4 and we get 8. So we use 4 of EC, that is epirubicin with cyclophosphamide, and follow that with paclitaxel or docetaxel with Herceptin 4. So that is how it becomes 8 of when we use targeted therapy. Now, targeted therapy, if you go by guidelines, it is supposed to be given for 1 year. That is the guidelines. Now, obviously, studies have been done, and in the Indian, you will find on the Indian studies, and then they found that 6 months is as good as 1 year. And then there's another study done which says 3 months is as good as 6 months. So these are the Badway keeps on, Tata keeps on doing all these studies. So the consensus, but the basic you're talking about chemotherapy is around. This is what I'm saying is 4 cycles, or 6 cycles or 8 cycles. Now, there's another thing is paclitaxel when it is given. Paclitaxel, some studies have said that the weekly paclitaxel is better than the 3 weekly paclitaxel. And then when you use that, so there are people giving the weekly. Now weekly 3 weekly, you make it into 3. So it becomes, so if you ask patients, no, we have 18 cycles, so you divide that. So 3 into 4 is 12 cycles. So, cycles is a very vague sort of a thing. So that's what I'm saying. So, and then next is the palliative chemotherapy. You keep on giving cycles of chemotherapy till the patient can tolerate. So there's the standard adjuvant, that is when you operate and you give chemotherapy, is a standard of 6 to 8 cycles. And palliative chemotherapy can go up to any number of cycles. Simple.
I take this opportunity to thank my colleagues, Dr. Joseph Sequeira and Dr. Dale Rodrigues, for this wonderful presentation and answering all the questions that have been put to us. I thank the F.I.A.M.C for this opportunity. And we miss our senior colleague today, Dr. Nicholas Antao, who had to travel to the States recently. I had big shoes to fill in, and we miss Dr. Antao on these forums, and I hope he comes back very quickly. to join us in the F.I.A.M. activities. Thank you, Sharon. Thank you, Dr. Giselle. And I hand over to Dr. Giselle for the vote of thanks.
Thank you, Susan. Good evening, everybody. It has been such an honor to be a part of this really wonderful event today. Cancer is always about focusing on the fight and not the fright. And if you want to fight, you should be aware. So awareness is power. And raising awareness about this very important issue of breast cancer requires dedication, commitment, and passion. We witnessed all of this in our speakers today. And on behalf of F.I.A.M., I would like to extend my heartfelt gratitude to our speakers, Dr. Joseph Sequeira, with all his years of experience. Thank you, Dr. Joseph, and Dr. Dale Rodrigues for all that you've got, for your time today. Special thanks to Dr. Susan Sauder, who's given up a really precious time and who has moderated this session so well. As Susan said, I can't forget Dr. Antao, who was responsible for this session today. He's conceived it and he's planned it. He gives his heart and soul to F.I.A.M. and we really miss him and we are indebted to him. I would like to thank all of you who've taken time out to come here today, but also thank all those who are silently working behind the scenes, namely Sharon, who is all the time working for us and planning everything quietly. And also Anil Sequeira for this YouTube link that he has given us today live. I want to thank the BOT members who are there with us, supporting us all the time. I would also like to thank the participants who have come here. Without them, all that we talk is really useless. Thank you for all your time on this Saturday evening. And thank you for all the questions that you've given us. And thank you also for teaching us today, Joseph and Dale, that early diagnosis is key. And also the ethical part that we have to give time to our patients, especially when we break the news. We have to counsel them because they are lost otherwise. Thank you so much, everybody, for making this event a huge success.
Good night and have a great weekend, everybody.
Thank you.
Good
Thank
night.
you.
Good night, everyone.
Good night.